All right, everybody, welcome to Optometric Education Consultants National Webinar Series Tuesday night edition. Tonight's topic is neuro-eye grand rounds, my favorite cases, and one of my favorite topics, and one of my favorite speakers, Dr. Chris Borgman. He's an associate professor at Southern College of Optometry in Memphis. He earned his optometry degree from Illinois College of Optometry and he completed a one-year residency in primary care and ocular disease at the Illinois Eye Institute in Chicago. He's lectured in numerous continuing education venues on the topic of primary care ocular disease, ocular manifestation of systemic diseases, and neuro-optometric diseases. So with that, it's my great pleasure. We've had him at several of our live meetings. I think Chris, this is your first virtual meeting for us. I know you can do a fantastic job. So with that, please take it away.
Wonderful. Well, thank you all for the opportunity. I'm glad to be back and looking forward to tonight. So appreciate this. A little bit of background. I was telling Joe a little bit ago, a couple of years ago, I made a catch on a meningioma, and so I got to work with neurosurgery and the referral stuff, and the neuro eye side of things have really been kind of taken off for me here the last handful of years or so. And so it's turned into something I really enjoy. So that's where a lot of these cases came from as we're seeing patients here at the clinic in Memphis with my residents and fourth year students predominantly. So I don't have any relevant financial relationships to disclose. I made a joke, I think, last time I spoke with y'all, Joe, about maybe someday if I do a good enough job, I'll have a financial relationship to disclose. But right now, I don't have anything. So all this is everything we go over is based upon my experience, my interpretation of the literature, and those sorts of things. So,
And Chris, consider your topic. I actually heard a neuro-ophthalmologist say this. No neuro-ophthalmologist ever had a financial disclosure.
that's fair. I can see why. Yeah, that makes sense. All right, so rules for this lecture. Again, I don't have any conflicts of interest or anything, so that's good. If you guys, I know you guys have access to the handouts. I always like it when you guys walk through these cases with me as if you're seeing the patient yourself, because these are ways we can learn and kind of work on our critical thinking or our differentials as we walk through these cases as I present them. So don't look ahead, walk through them with me. I'm not perfect. Man, I've made so many mistakes in my career, and I try to learn from them and share them with colleagues and students and whatnot. So you'll hear me reference sometimes that I maybe mess something up in hopes that you all don't make the same mistake should you run across something similar, you know. And just because we call them maybe brain teasers or neuro eye cases, they don't always, it doesn't always mean that they're zebras and, you know, off the beaten path. Some of these are pretty straightforward if you're kind of thinking through it. So don't be misled on that. Use your logic, kind of follow through these cases. And my email's here if anybody would like to email me. That's totally okay. I love chatting with colleagues behind the scenes and stuff. So I don't mind at all. So with that, setting the ground rules, let's talk about case number one here. So this case is one that I kind of inherited here at our clinic. I was kind of involved peripherally, but mainly what I'm describing to you on this slide is where I inherited this patient officially under my care. And so this is a 30-year-old male who, for the last several years, as you can see in his ocular history, has progressively been losing vision significantly during our follow-ups there at the clinic. And that's mainly his complaint. My vision's getting worse over time. He had some workup along the way, but until it got to me, like I said, I was mainly peripherally involved. He disappeared a little bit, so there were some gaps in care there, but this is again where I'm picking him up. It's getting harder to work. He is a local chef, and so you can imagine if he is losing his vision like that, it's getting harder and harder to prepare people's food safely, and so there's some issues there we got to work through. And so he's just struggling to support himself. He's been a long-term diabetic, hypertension, obesity. If you guys remember the movie The Green Mile, one of the main characters there, oh my goodness, why am I drawing a blank? The big guy, John.
Michael Duncan Smith, I think was his name.
Yeah, and the character was, I thought it was John something, but that's fine. Yeah, him. This guy is like almost like a spitting image of him. That's what it reminded me of. So he's a big guy. He's overweight. Those sorts of things. So. He's on the typical meds that you would expect here. No surprises there for what I know of his history. He doesn't drink or smoke. Those are obviously risk factors for things that can pop up. So again, trying to paint the picture of the timeline over these several years of his vision slowly worsening over time. Now, I don't know how familiar you guys are with Color DX. I believe this is a form of the Rabin cone contrast kind of protocol. But we have this here at our clinic. Again, I don't have any financial disclosures. I'm just sharing what we have. And so he had also been complaining of his color sense kind of changing or color discrimination. And so we'll commonly run this on those types of patients to see if we can get something a little more quantitative than maybe Ishihara or HRR or some of those. And so as you can see here, the way this typically works is this is going to be the right eye here on the left part of your screen and then the left eye over here. And the blue is where he's actually sensing the blue color the best through this test. And so he's getting a little bit of red on the right eye, no green, doing pretty good on the blue. And then the same thing on the left eye. His red and green discrimination is basically zero. And he's got a little bit of blue sensation there, discrimination, but not good nonetheless. And so something going on with his color vision here as well. And he's noticing that's been acquired or changing there as well. So when we dilate them and look in the back, my hope is that these photos show up okay for you guys. But what I'm hoping draws your attention is the temporal aspect of each nerve. I'm trying to show you here that they are pale in color. And especially if you compare the nasal side to the temporal side here, that temporal aspect is certainly pale. So some people ask if this is a artifact from like an overly exposed photo. It's not. This is exactly how it showed up clinically with that. So,
And Chris, it's really important in neuro-op to have photos. There are a couple of things we're always taken with OCT. Visual fields are still important, and so are photos. And I don't mean wide field imaging, but taking the photo, I think, is critically important because you can look at that and you can justify that clinical exam in your mind when you think, was that pale? Is that, and you look at it, and it's really pretty clear to me that you got temporal pallor.
yeah. Oh, I
Photos
love
are
that you said that.
critically important.
I kind of say the same thing in clinic. Let's get some photos and fields are actually when I see something weird with the nerve, and tell me if you disagree, but a good, reliable visual field is almost worth more than OCT in many cases because it helps localize and helps me with my differentials and so I would actually put fields a little bit above OCT. Obviously want them all, but what do you think on that, Dr.
I
Saka?
I agree, but I also give the admonition, if you're ever to the audience, if you're ever doing anything in optic nerve, get a field. Don't skip the field. Even if their vision's terrible, try a field. At least try a confrontation field. Optic nerve, field.
Yep. Yes, sir. That's great advice. I agree. I had one of my colleagues talk to me today about one like this, and there was one eye who was basically light perception, where she was like, "Well, I can't do the field on that eye," and I was like, "Well, you could still do it on the good eye because if the good eye is perfect, you can help localize that down to the optic nerve. So even if you, as long as you have one decent functioning eye, you might be able to gather some information with that with the field anyway. So part of the differential working stuff out. So perfect. All right. Let's keep going. So just zooming in here, just again, kind of show you the temporal pallor. It's pretty obvious there as well, but just being clear. So, all right. So these are the fields. These are 30-2s. Um, I generally will do a 30-2 for neuro and 24-2 for glaucoma, but I'm a little less strict on that than I used to be. I think both obviously are just fine as long as we're using them. And then really what I wanted to highlight here is if you notice paracentrally and centrally, there's some depressions near fixation. So over here on the left eye, there's some depressions. And on the right eye specifically, there's some depressions here. And the grayscale's picking it up a little bit, and that's what it's trying to highlight there. So that when we get these central paracentral scotomas, those are interesting because it kind of narrows down some of the options. Usually that's going to be, or it could be papillomacular bundle associated with that temporal pallor, of course, from the nerve. And it helps, again, narrow down the differentials for things to think about as we walk through this. I'll go through those. Anytime I get something near fixation here, paracentral, central, I kind of want to zoom in and do a 10-2. So this is the 10-2 field that we followed up on him. And just kind of flipping back and forth here, I just wanted to highlight that, if we first glance at these paracentrals, from our perspective as the doctor, it might not look like these are that bad. I mean, yes, they're there, but when we zoom in, we can really see the denseness of these 10-2s. And so I guess a learning point that I like to show students with this particular case is that don't blow this off and think this is nothing. When we zoom in with the 10-2, it can actually give us a better sense. So these field defects could be worse than what we think. And when we see this, I think this correlates pretty well with this guy's 2200 vision, or that severe vision loss there as well. So, all right. Here
Actually,
is,
going back, if you go
yeah,
back to, you said he had 2200 vision?
2200. Well, that's where he ended up. The
Okay.
timeline here, he would have been, by the time I got him, around that 2100 to 2200 here, probably.
If you back up one more, my clinical pearls for neuro-op, and I do the neuro-op in our practice. I do 24s,
Okay.
and 24 is good for me. Faster you can. See, the faster is what I'm going to use,
Okay.
because neuro-op is not subtle. You're not looking for a small, shallow, fluctuating scotoma and glaucoma. It's not subtle. I want to get as quickly as I can. And paramount, look at the grayscale. The grayscale rules in neuro-op disease. So if you look at the pattern deviation, you're going to miss the neurogenicity of the field loss.
I love that you said that, because I feel like I was taught the grayscale was like a coffee cup placeholder, and I've been
Mhm.
using it kind of as a weather vane for years. It'll at least tell me which way the wind is blowing, right? And so I'm glad to
Mhm.
hear that
Oh
that
yeah,
you agree to
yeah. That's
use that.
that's what they said. They were wrong. I
I'm with
love
you.
they're wrong a lot.
Yeah, yeah, I'm with you on that for sure. So, all right, so 10-2, zooming in, notice the expansion there, that this is denser than what we may have thought on the 30-2. Here is the patient's serous RNFL scan here, and kind of what I wanted to highlight here is a little bit of maybe some temporal thinning. This is kind of, especially in the left eye, showing up in that general area there as well. You can see it on the clock hours.
Hey Chris,
Uh,
real quick, the question
yeah,
just came in. Curiosity, were they say those are the real fields, right?
those are yeah, these are the real fields. Yeah.
And why? Somebody's asking why the RX different between the eyes or slides.
The RX-50. Ah, yes. So I will tell you that my third years are not good at following up with what I want them to do. So in our clinic, I would say his actual RX was close to this here. And then when we repeated it at a different visit, my third years neglected to look as close as they should have at the RX. So
That's a good pickup of one of our audience members. I thought
yeah,
that's an excellent explanation. I've been there. That's
yeah,
why I left academia after 28 years and 2 days.
man.
What I loved about the students is when I would tell them, put their prescription in and let the machine tell you what to do. And rather than put their distance prescription in, they put in the prescription from the last visual field, and it adds +3, and then
Yeah.
+3 more. Before you know it, yeah, I've got a +12 trial lens. Where'd that come from? All right, I'm sorry. Go
Yeah,
ahead.
no, no, I love it. I love it. Yeah, I love my students, but there's some days I'm like, really? Come on, guys. Like, think through this a little bit. So, but they're learning. And I remember being a third year and I made some silly mistakes along the way. So I try not to beat them up too bad, but I definitely, yeah, that's what happened there. So great pickup. Great pickup. Okay. So, I don't know. I'm assuming all practices don't have multiple OCTs, but we have three at SCO. We have the Cirrus, we have the Spectralis, like here, and we also have the OptiView OCTs. And so, what I'll do sometimes is I'll take patients and I'll kind of put them on different machines just to kind of see what the information may tell me, which might be subtly different. And the reason I did the Spectralis on this one is because it has a specific temporal sector here that kind of puts more than one clock hour together. And I wanted to see what that kind of looked like on the Spectralis. Around this time, the Spectralis was new and I was trying to wrap my arms around it. And so I'm kind of a Cirrus guy trained on anyway. And so I'm trying to figure out the pros and cons of when to choose these. So knowing that the clock hour is there, that's why I generally chose this one just to kind of see what it would show. So zooming in here, as we could look at this, you can see the temporal section here is statistically lower than we would expect. You can see that in both sides here, left and right. And this was kind of one of the original ones that we got early in his disease course. I'll show you a later one here in a minute. Here are his just regular MAC thickness scans, just to show you that in general, the overall contour looks good. The layers look generally okay. There doesn't seem to be any maculopathy that would explain his reduced vision, structurally here anyway. So that was something I wanted to look at, make sure there wasn't macedema. He is diabetic, right? Making sure there wasn't anything funny going on there. So if we zoom in though, and we look at his ganglion cell layer, which again, this is on the spectralis, you can kind of see, if we look up here, kind of the redder colors are obviously the hotter colors, but you'll notice kind of temporally here is a little bit thinner. It's not as hot as the redder kind of colors around the edges here, and that's kind of on both sides here. So superior, inferior, a little bit hotter, but thinner nasally. And that's kind of weird because sometimes neural things can show up nasal on GCC, and that's a clue. But also remember the papillomacular bundle is coming straight from that temporal nerve and feeding this general area. So it would make sense that temporal pallor would probably have some dropout here of the ganglion cell. So to me, this kind of makes sense with what we're seeing so far in this patient. So maybe an early or the optic neuropathy consistent with the clinical exam and being supported with the GCC loss here as well. This is just a comparison of actually my GCC because believe it or not, at the time, me and him were similar in age. And so just to show you the thinning here compared to a more statistical norm of what this should be like on the spectralis, this I think makes it even more obvious to see the thinning on this patient nasally there compared to a comparison there. So these are just normals on the bottom as a visual. So, all right. All right. Also, I have been burned a couple times on some weird RPE things, and so I wanted to get an autofluorescence on the spectralis since his nose was in the machine. Let's get as much data as we can just to hunt for some things. Again, because if he's got those central scotomas, I'm looking for things around the macula as well. And these are a little blurry, but really nothing going on here. Autofluorescence was largely just normal, and so I didn't really get a clue here, but sometimes it's nice to know what things aren't so that we can help out with the differential. And so this is just something that was helpful for me there. So as we continue to follow this guy over time, this is over about a year's time, roughly. You can now see the progression that has occurred of his temporal thinning. Statistically, again, has become more thin. We're losing more ganglion cells. So this guy has this progressive optic neuropathy that keeps getting worse, hence the loss of his vision as well. So this is just zooming in, showing you again that temporal thinning, and we're losing some of that inferior temporal too on the left eye. But just a progressive optic neuropathy bilaterally, kind of a scary thing for a young guy as well. So this would be my first polling question now that we've painted this picture. What do you guys think might be the best next step for this case? And Joe, I believe you're going to load the
Yep,
polls there.
it is open.
Okay.
So what you can read it, you can read it if you like, the
Yeah.
audience.
So the best next step for this case, what do you think? Should we do a brain MRI, a brain CT scan, maybe consider some lab work, or could we do some electrophysiology? And what I mean by that is ERG and VEP predominantly. What do you guys think? What would be your next best step here? And I'll show you what we did. It doesn't mean it was the right thing, but I think it was a reasonable thing to do. And I would love to get some insight along the way on what you all think.
Okay, they're coming in. We'll give them a few more seconds to think about it.
Okay.
We do have a clear winner right now,
Mm,
or a clear preference.
okay.
All right, give it a couple more seconds. All right.
Awesome.
And our winner is a brain MRI at about 57%.
Yeah.
And brain CT lab work and electrophysiology are all about the same at around 15%.
Interesting.
Excellent,
Okay.
excellent.
Yeah, yeah. Yeah, that was the decision we made. We decided to go with a brain MRI at this point because we have an unexplained optic neuropathy in a young person. There's several red flags there that make me really nervous, and so I think ruling out some of the really big bad things neurologically is a good idea. So what I did was we ordered a brain MRI with contrast. We also did an orbit MRI with contrast. Dr. Stalker, I'd love to get your opinion on this, but given his young age, demyelination was certainly on the table. So maybe things like NMO might be something to think about, which can show up here. Would you agree with that or no?
Well, let's think about a couple things. First off, next steps, you ordered two scans. You ordered an orbital and a brain MRI with and without contrast. And that's absolutely appropriate. So remember, for the audience, the optic nerve, you got four parts to the optic nerve. You got the papilla, you've got the orbital part, you got the canalicular part going through the optic canal, and after that, up to the chiasm, you got the prechiasmal part. That's four parts of the optic nerve. So the only way to get all parts of the optic nerve is orbits and brain with and without contrast fat suppression. Now, in the absence of pain, I would not think a demyelinating inflammatory response here. I would consider infectious. I think blood work is good. Imaging is good. NMO is a demyelinating disease. MOGAD is a demyelinating disease, often with visible optic neuropathy, often disc swelling, and they are often painful, much like optic neuritis. It wouldn't be one of my first tests to order because it's a little harder to get and more expensive and often not covered.
Yes, sir. Love it. And so I was also curious here, since there's a lot of things that can happen in these areas. Pituitary tumor was on my list as well. Brain tumor elsewhere, otherwise possible. And so to me, when I get that clear MRI, to me, I generally will say we ruled out the really big and bad things, although we didn't rule out all of them per se. But I like that. So okay, cool. So next steps then is what we did was we jumped to labs. We're like, all right, this young guy, it's the brain MRI is normal, the orbit MRI is normal. What can cause central or paracentral scotomas? And there are some things that are possible, right? We should look at a complete blood cell count with differential. We have leukemia can sometimes infiltrate the nerve. Might not be bilateral like this in most cases, but something to check for. Looking for anemia as well. And then vitamin deficiencies are certainly something to think about here as well. So generally B1, B12, and folate are I believe, the big ones there to look at, which were normal in his case. And then we also checked an RPR because syphilis being the great masquerader, and at least locally here in Memphis, the trends are increasing upwards for syphilis, and I believe that's kind of a national thing. There's a trend upward with that. So syphilis is always on the table as a differential to think about in these cases as well. But those are what we checked on him, and those were all normal. And so I was like,
Chris,
yeah, go ahead.
refresh us. How long has this been going on for?
This has been going on for about 4 years from when he went from 2025 to when I kind of picked him up over about a 4 year span of about 2,200 there. So yeah, 4 years.
Okay, so I hate to say this, but that's how long you have to work them up. It's been going for 4 years. You got 4 years to figure this out. What I'm saying to the audience is you don't send a person like this to the ER. It's not an emergency. It's progressive. You've got some time to think and pick your tests.
That's a great point. I love that. I love that. All right, now what do you guys want to do? We're like, oh man, what's next? Well, if you notice the list that we went on, we did brain MRI or imaging, then we did lab work, and then what was that last thing? But maybe some more lab work, right? So one of the things here that this, if the timing worked out, if I would have said back around COVID time, if you guys remember this ID or IRD, I believe Spark was kind of sponsoring this. We had access to some free genetic testing. And so one of the things I started thinking about was, well, does this guy have hereditary optic neuropathy. I mean, the MRI was normal, the labs were normal. Are we missing something else? And so this was identify your IRD, your inherited retinal disease. But if you look at the actual panel, instead of just going with the name, there are some mutations that were checked in this panel to look for specific optic neuropathies like dominant optic atrophy. And so my thought was I could test them for that and see if there was anything genetic going on here. So I was trying to double up on this with that. So um, what we got to hit back on, we got several hits of undetermined significance. And so to save time, what I did was I put the one in red that may play a role with reduced central vision loss. And what you'll notice in red, hopefully you guys can see it, but it basically says that specific gene, the TTLL5, is associated, which doesn't mean we know that it causes it. It's associated with possible autosomal recessive cone rod dystrophy. And so if we think of cone rod dystrophies, if cones are generally affected first and cone rod dystrophies followed by rods later, maybe the macula is being involved because of the density of the cones in the fovea and macular areas. And so maybe this would account for some of his vision reduction or paracentral scotomas. And so when that came up, I was like, huh, that's interesting. I didn't see anything on the OCT per se, but you don't always get that. And so how do I make sure or rule this out? Then I decided to run this guy through some electrophysiology, which I thought would be kind of fun to work through the differentials today with this. So if you think about that first question, it was brain MRI, brain CT, and then lab work, and we're working through that. The last thing on that list was electrophysiology. So this leads me to my second question for polling. What is your comfort level with electrophysiology testing?
Are you an expert? You can interpret them. I know the difference between VEP and ERG. That's about it. Not great, but I need a good review of electro testing.
I feel like in the last few years, they've kind of re-looked at VEPs and ERGs and some of this electrophysiology in the appropriate context with patients and found that maybe there's some use there. And that certainly has been my experience. I'm probably biased. I do electrophysiology every Friday. I'm the electro guy, and so I have access to it here. And so I find it to be helpful to, I guess what I would say, electrically dissect the retina and help narrow down where maybe some of these problems might be coming from to help figure it out. So this was a case I thought would work out pretty good.
Well, as we let a few more seconds pass so the audience can vote, a question came in: was there family history of vision loss? Any significant family history?
There wasn't. He was technically, I believe, adopted or estranged from his family, and so he didn't have great information on that to share. So I guess there could have been, but nothing that we were aware of.
Well, the result of your question is most people say not great. I need a good review. Some people do know the difference between VEP and ERG. Some people can interpret, but nobody claims to be an expert, which I think is probably very, very reasonable.
Yeah, I'm not an expert either, even though I do it. But I can. My hope was that you guys would largely be around O, C, and D, so that we could walk through a quick review, which is what we're going to do. So
That's
we're
what they
through it, it's
were.
worked out. So
Hmm.
awesome. All right. So I made this slide to show my students because they'll ask me and we'll kind of walk through this in clinic. So just to orient ourselves, this is a cross section of the retina. We have the ganglion cells on the inner part of the eye, right? The bipolar cells and then the photoreceptors and the RPE and whatnot. And so what I was going to try to show you guys is remember that when light enters the eye, it's going to travel all the way back to the photoreceptors like this. Let's see if I get my Oh, where'd it go? Oh, sorry. Let me do this. Is it going to work? Darn. All right. So light is going to pass all the way through to the back of the eye, through all the layers, and it's going to hit those receptors. It's going to cause a chemical reaction in the photoreceptors, which are then going to cause an electrical signal to be generated and ultimately passed on through the visual pathway to the brain. So I find that amazing that light gets converted to chemical, and then we get an electrical signal that we can actually measure in some capacity, which is cool. So we get the first wave as the photoreceptors start their signal. That's going to be generally your ERG A wave. So A wave is generally outer retina, predominantly the photoreceptors. And then we have the B wave, the ERG B wave, which is going to be predominantly the bipolar cells, usually the on bipolar cells. These are where large contributions come from. And then we have the ability to measure some ganglion cell function in a couple ways with either the pattern ERG and or the VEP if we use these in conjunction. And so what I'm trying to show you here is not necessarily to be an expert, but just to kind of show that we have the ability to, in a way, dissect the retina to see what's working electrically to give us a clue of where to go next by using these in conjunction with each other. And so this example here of the VEP, this is when we have the diopsis unit, which is largely out of commission right now because the company doesn't really service it at all. But this, when we did have service to it, this is when I was using this. So with the VEP, we're measuring the visual signal from basically the spectacle plane to V1 and looking at the speed and the strength of it. And generally what we're getting here with the right eye and the left eye is either noise or late small signals that really aren't very helpful. So there's something going on with the signal. We kind of know that based upon the visual acuity being down. When we compare that to what a normal one should look like, these peaks right here, your P100 peaks, should be really easy to identify, should be around 100 milliseconds. And so this is the normal on the left. The patient's on the right is late and low, suggesting there's a problem in the visual pathway. We're going to come back to that. So this is going to be evidence that there's clearly something going on, which we know about. You can measure it at different spatial frequencies, which in this case we did a 64 by 64, which is kind of a checkerboard pattern of 64 horizontally and vertically, checkerboard boxes that are alternating between black and white. And then these signals here, the green is the right eye, the kind of brownish orange is the left eye. And you can see the peaks here are actually late. They're around 160 milliseconds, which is massively late. So the signal's going through, but it's really late. Compared to what normal should look like here as far as the speed up more around 100 milliseconds. So that's suggestive there's a problem there. All right. The pattern ERG should be a sinusoidal wave pattern, and this is kind of irregular here. And so if I show you a normal, you can see the sinusoidal kind of smooth wave. And his is kind of falling apart here like this. So it's there, but it's really kind of sporadic and irregular. And so this is suggestive of ganglion cell and or macula dysfunction, which is kind of what we know so far. But so the VEP and the pattern ERG so far is not the most helpful in this case. But when we conjoin it with the ERG, we're going to get some additional information that I'm going to show you. So part of the ERG process is also separating out cones and rods. Now, if you remember, the genetic testing might have shown the cone rod dystrophy. So I really do need to kind of check function of rods and cones to get a sense for what's going on. So scotopic obviously means dim lights or dark conditions. And since the rods are more sensitive in the dark than cones are, this is going to be mainly our rod function here. We're looking for this peak, kind of this hill right here. And if you compare that to a normal, we're expecting a normal peak around, say, 100 milliseconds or so here. And you can see the similarity between the patients on the top and the normal comparison below. And so this would suggest that the rods are functioning normally in this person so far, in this patient. So hopefully what you're seeing is I have one signal that's low, one that's good, and I'm going to kind of use those together to dictate where to go next. All right, next step. This is your textbook ERG that you always see with the A wave coming down and then the B wave over here. Again, the A wave, as we mentioned earlier, is largely photoreceptors. Since we're using scotopic conditions here, this is largely reflecting rod function. And then we're going to get pretty good response here. The rods are functioning, and then we're getting a bipolar response that's higher than the baseline of where we started, which is what we would expect also in a normal. So again, kind of seeing the similarities here between the normal and what the patient has. This is suggesting that the rods are working pretty darn well for him. Now, if we switch from scotopic to photopic after this, That's where we're going to start getting the cones involved. And if you remember, again, the testing suggested maybe a cone rod dystrophy to think about. So I'm actually most interested in the cones. And so because the cones are only about 6 to 7 million or so in the retina compared to 140 or so million, 120 to 140 million rods, the signal is going to be smaller in amplitude anyway. And so, but nonetheless, you can still get a decent A wave and a B wave that comes up here like this. When you compare that to the normal, we're at least getting a cone response. And there's a couple different ways to measure this. You can measure it in this particular way under photopic conditions where we're just flashing the light. But you can also do like a strobe light pattern. And that's on the next part of the ERG here, this flicker. So rods can only keep up to about 10 to 15 hertz, and then they die off. They can't keep up. Well, cones can, and a healthy cone can keep up largely up to around 50 hertz, maybe 55. So if we do a 30 hertz or a 32, it's basically a comfortable jog for the cones to keep up where the rods can't keep up. And so we're eliminating the rods and isolating the cones with this frequency. And we're looking for this beautiful sinusoidal wave pattern here, which as you compare to the normal, this patient has. So we go through this, the rods are functioning well, the cones are functioning well, but then the VEP kind of falls apart as well as the ganglion cell. And so by doing that, we can show cones, bipolar cells, the rods, all that are working fine. Where things fall apart is actually more the inner retina here. So the A wave was fine. The B wave was fine based upon the ERG, but then the pattern ERG and the VEP kind of fall apart. And so it's just another way to dissect the retina and, to see where the issue is going to be. So also part of the differential here is now I can rule out cone rod dystrophies because the cones and rods are working fine with the ERG. So part of the differential there. So hopefully that kind of makes sense as we follow through that to end up kind of at this optic neuropathy. All right. That was ERG is, I should also mention with the ERG when we get back to this, hopefully you notice that an ERG is not one test, it's a series of tests. And I totally messed that up when I was a student. It's a minimum of 4 tests, can be 5 or 6, but generally 4 to 5. And that's what we're looking at. We're separating rods and cones and things like that. So, but now I feel confident that this is an optic neuropathy. And so now we got to rethink our differentials, right? We have optic atrophy. We've kind of worked through some of these. It's not a tumor. It's not papilledema. It doesn't act like glaucoma or look like glaucoma. And so now we're kind of down in here. We looked at some of the nutritional things. The vitamin deficiencies were generally, I mean, we're good. So I'm like, man, what else? I did check for dominant optic atrophy under the hereditary, but it's something to think about here is Leber's hereditary optic neuropathy. If you go back to that panel of what they were checking for hereditary disorders, dominant optic atrophy was in the panel, but the company never paid for Leber's hereditary optic neuropathy. So we technically didn't check for it. And so as we went through this, and I knew that, what I decided to do next is when I started thinking about his case, I'm like, this young guy with a progressive vision change of an optic neuropathy of the temporal nerve. In hindsight, Leber's hereditary optic neuropathy should have risen up my list a little faster than it did. So I ended up checking him with this particular company. There's multiple companies that you could do this for. And he was, let me ask this here. So polling question number 3, before I
Mhm.
give you the answer, what's your comfort level with ordering genetic testing? I'll let you guys think it over and answer how you wish. I'll just say that my comfort level has improved since maybe 2019, 2020, when that ID or IRD test came out and we kind of got access to it. It was intimidating in the beginning, but I feel like it's a pretty great test when it's indicated for the right person and patient. So, as you guys are thinking about that, Dr. Salker, I'd love to hear your insight. Do you order genetic testing? Is it something you do or think about or think is worthwhile?
I think it's worthwhile for certain conditions. We've been doing some in our practice in terms of macular degeneration, but we've actually ran into a little bit of problem with a company that we're using, so we have actually put that on hold for now.
Yes, sir. Yes, sir.
but I think it's very helpful. You're all caught up in the questions right now, so you're good on that, Chris. I'm going to let them go for just a bit. Actually, I'm going to close the poll now, give her display. The majority have never ordered genetic testing before. Some have ordered a couple times a year, and one person orders genetic testing on a monthly basis.
Okay. Wow. Okay. Great.
Excellent.
Yeah. So hopefully it'll catch on. It doesn't need to be as intimidating as I guess I thought it was when I first did it. There's different ways or different samples you could submit. Some do spit, some do the buccal cheek swabs on the inside of the cheek. Some retina guys I know will do, as they're doing like a fluorescein angiography, if they're injecting the fluorescein dye, they'll grab some blood basically while they're there. But I would say I've pretty much almost exclusively, I'll just do the buccal cheek swab. It's easy, it's painless. I tell patients it literally costs you cheek cells and spit, and they kind of chuckle at that, and then we get the sample. So, and then I'll mail it in to the lab and get the results back. Typically in 4 to 6 weeks, sometimes 8 weeks, but it just depends with that. So, it's not as intimidating as what I thought it was ever going to be. In this case, this person's came back positive for Labors. The mutation that we have on here, it's going to be the 14484 mutation, and this is a pathogenic variant. And so, as we worked through this and eliminated some differentials, we finally got the answer. This guy has a Labors hereditary optic neuropathy, and so this is one of the markers for that. If I go back here, what you'll notice, this says homoplasmic, and what that is in reference to is the amount of abnormal or mutated mitochondria within the cells of the sample. And so you can have a mix of normal and abnormal. So in this case, normal is the green, the gray is the abnormal, the mutated ones in these examples. So if it's a mix of anything basically other than 100%, it's a heteroplasmy. But when they become 100%, that becomes the homoplasmy. And the tipping point that has kind of been discussed in the literature is once you reach around that 75% mutation level, the mitochondria, the ATP requirements of the cell can't keep up, and you kind of tip over into dysfunction as the amount of ATP can't be produced that the cell needs. So it's around that 75% mark. That's why that might be helpful. In this patient's case, if you remembered, his was 100%, and so he's well above the believed cutoff mark for that. So final diagnosis here, Leber's hereditary optic neuropathy. This is the first one that I ever ran across and diagnosed as the workup. In hindsight, I think this was not a clunky workup, but now that I've been through it a couple times with a couple other patients, I feel like I've streamlined it. But what's that saying from the movie Moneyball? The first person through the wall gets bloodied the most. Like the first time you do something, it takes a little bit of learning, you're feeling it out, and it progressively gets better. And so this is I call this kind of a clunky workup on this patient. But I was happy that we got the right answer in the end with this. So anyway, with Leber's, it's the second most common inherited optic neuropathy. Dominant optic atrophy is technically more common. It's a mitochondrial disease. This has been around a long time from the 1800s, where it was kind of first described by von Graeff and Leber. Around 90 to 95% of these patients will have one of these three main mutations. And the most common here, in around 60 to 90%, is this 778 mutation. In our patient, he was the second most common, the 14484. So number 2 here with that. One may go, well, maybe it doesn't matter clinically, but it does, because your prognoses change depending on the mutation that you have. Our patient, even though he's 2200, technically has the best visual prognosis of the three most common here in this case. So anyway, he fits that pretty well. So this is ultimately, because of the mutation, it messes with ATP production in the oxidative phosphorylation pathway. So when I lecture on this, usually I'll go, does anybody want to go back to biochem and relearn all this? And everyone's eyes glaze over and they roll their eyes a bit. We don't need to do any of that. But if you remember the metabolic activity of the optic nerve and the retina is highly metabolically active. So therefore, any messing with the ATP production that is required for those cells to work appropriately, they're almost exquisitely sensitive, especially in the papillomacular bundle and the foveal areas because they feed each other, right? The papillomacular bundle. So anyway, in this case, the reduced ATP production increases free radicals, leads to metabolic problems with the ganglion cells, and ultimately over time, those ganglion cells and axons will atrophy, leading to the pallor that you see predominantly temporally in the nerves. Because this is passed on from basically mitochondria are only passed on from the mother side. If you're a male that has this, you cannot pass it on to your offspring, but women can be carriers of this. So this guy would have gotten it from his mother's side. This is predominantly affecting males much more than females with this. Um, the average age of onset is around 10 to 30 years. If you remember his age, I got him around 30, but his symptoms had started more mid 20s, so he kind of fits that. And then it's basically going to progress around 2200. So we got him once we got him diagnosed, was late in the disease process with that. And most commonly, we're going to be that central, paracentral, cecocentral scotomas, which is also what he had. So the red arrows, when I put them on here, are generally showing what the patient had in this case so that you can kind of see where he fits. All right. So again, mitochondria are only passed on by the mother. And so this is good for patients. Like if you catch this as a teenager or in, say, in early 20s, maybe they have not started their family. Some people might consider this in part of their family planning. And so it's important to know that fathers cannot pass this on to their offspring because the mitochondria are only passed on the mother's side. So it's kind of an educational point if patients ask if you run across this. Although the mitochondria are obviously in every cell in the body because of the ATP required for the metabolism, it's weird that these patients almost exclusively have ocular involvement, but no systemic involvement. I've not run across a great reason for why that is. If you made me guess, which I honestly don't know, I would say because of the high metabolic activity that's required in the retina and optic nerve for us to see, that's probably makes it more sensitive to a dip in ATP and mitochondrial disorders. That would be my guess. All right. So again, pass from mother to offspring. It's not uncommon, but it's not common either. You can have a broad range of onset of age, so really any age, but the vast majority are going to be around that 15 to 35 year mark. And usually it doesn't happen under the age of 12, but by the time they're 50, the extreme majority of patients would have at least started symptoms. So again, that young male 15 to 30, 15 to 35 is a pretty good age range for when symptoms start. That when I hear that now, my ears perk up a little bit and I go, well, could this be labors? Is this something I need in my differential with that? Before I go here, Dr. Stock, I'm just curious, how many labors, hereditary optic neuropathies have you seen before? I know it's not super common.
Oh, I've only seen a handful.
Yeah, okay. At this point here in Memphis, I never saw them prior to Memphis, but I've seen three in my 12 years here that I've at least diagnosed and managed this way. So I'm always curious, but just have the three so far. All right. So other risk factors, these should kind of make sense. Like smoking puts added stress on mitochondria, and since the mitochondria are already stressed from the mutation, smoking can increase that risk of vision loss. So I think we should counsel patients on stopping smoking. There's really nothing good that comes from it anyway, but this is an extra thing that we should counsel them on. And then some authors have suggested avoiding alcohol also from maybe the metabolism standpoint or the metabolic debris, not metabolic debris, the byproducts of breaking down alcohol could lead to some stress on the nerves and the mess with vision as well. So the general thing is definitely counsel them on smoking, and we probably would counsel them on avoiding alcohol as well if possible. So, all right. Cool. All right. So classic presentation. I mean, if you're in the trenches and it should kind of fit this general profile, should be acute, painless vision loss over time, generally plateauing around the 2200 mark. There's going to be color vision abnormalities. That's what our patient had. Central or cecocentral scotomas, again, what this patient had. Temporal pallor later in the stages, again, what this patient had. The second eye is pretty much going to happen within a few months, if not very similar at the same time or within a few months of the symptom onset. And the extreme majority are at least going to happen in that first year. And many of them have some really poor vision loss. The outcome is not great for a lot of these patients. So low vision consult is obviously something to think about in these patients. Without getting in the weeds too much, a couple of years ago, around 2017, they came up with kind of these new stages of this. It's just kind of separated out based upon the onset, the timeline from the onset of the symptoms, and you can see where chronic is around 12 months from onset. Our patient was 4 years, so he's clearly into that chronic category at this point. And around this 2017 mark, there was some consensus guidelines on the management of Leber's hereditary optic neuropathy. And what really kind of came out in this or was recommended was the medication, the idebenone, which, as far as I'm aware, is only available in Europe. So it's not a great thing or anything that's really available here in the U.S. For most patients. But nonetheless, it's talked about in the literature. We'll kind of see where it comes out. So at this point, there really is no cure. Prognosis is generally poor. Therefore, I think low vision is a wonderful referral for this. If we look back at the history of things that have been looked at, look at this exhaustive list. I mean, man, there's been so many things that have been tried with underwhelming help, basically. Insufficient evidence to really say it does much. And so where I think it would be cool is gene therapy in the future. This might be a pretty cool opportunity for that. But as far as I know, that's not cleared the major hurdles yet. And so maybe the most popular actual treatment is idebenone, which is not wildly available for a lot of people. And so we're really kind of left with monitoring and educating and low vision consult with these patients for the most part. Should you be interested in how idebenone works, it's similar to coenzyme Q10, in which it's trying to help the electron transport chain travel from one oxidative phosphorylation complex like 1, 2, and 3, helping to take those electrons and pass them on and kind of bypass the problem. Coenzyme Q10 doesn't pass the blood-brain barrier, so it doesn't really work that well, but idebenone does, hence maybe better penetration into the retina and whatnot. It's really not had as good of an outcome as we had wanted, but it technically is available out there for patients that meet those criteria. And this is just showing the electron transport chain. The idebenone is grabbing those electrons and bypassing the problem to get to complex 3 to then pass it on and produce ATP. This is biochem stuff, not the most exciting, but if you like the weeds like I do sometimes seeing this can be helpful to see where this is exerting its effect, even though it's modest at best. So, all right. So if we go back to this patient, per those guidelines and whatnot, they recommend if it's been less than a year, you could try idebenone if you have access to it, which we didn't, but his has been well over that 1 year, and so he's not a candidate. And so there's really nothing that we could recommend for him in this case. And so we sent him to low vision. He was able to get some devices that helped him continue his employment, which is a win, right? He's still able to support himself. We talked about the genetic counseling. Should he choose to start a family? He has not yet, but should he choose to do so? And we also counseled him on smoking and whatnot there as well. So I feel like we handled it the best we could for this guy, considering the circumstances with that. So
It's a very bad disease. I think the really important take home for this is age, sex, one eye leading the other in a relatively rapid succession.
yep. Yes, sir. Yes, sir. All right, cool. Should I pause there for questions or keep going, Dr.
No,
Sauer?
we are good because
Okay.
I have looked at the chat and we're good.
Okay, wonderful. All right, let's go on to case number 2. This is a pretty cool case that I saw through our primary care, or I'm sorry, through my ocular disease clinic that was referred from our primary care. This is a 21-year-old female who had moved from out of state to go to nursing school here locally in Memphis and was trying to reestablish care. So I didn't have great history, but nonetheless, this is what I got as far as getting the records and things like that. So she has said her vision is generally stable. She does get headaches. There was a question of papilledema at that primary care exam about a month prior, which is also what kind of stimulated the appointment with me to kind of tease that apart and see if we needed to do anything. I love it when patients, when I ask them, hey, do you have anything going on in your medical history, like anything? And she goes, oh, nothing important. And then she throws out, I have a brain cyst. I'm like, well, no, I kind of need to know that. But I guess it goes to show sometimes patients don't understand that the eyes are connected to the brain like that. And so we need to be very thorough in our exam history. So I'm amazed that sometimes patients leave out things that I really want to know, and then they tell me other things that have no bearing on the case at all. But in this case, I'm glad she at least passively brought it up. And when she did, she's like, yeah, I was seeing a neurosurgeon back in my hometown, but and I was supposed to reestablish care when I got here, but I haven't yet. Should I do that? And I'm like, yeah, you should probably do that. I would like to point out in her meds, and I totally overlooked this at the first time, notice that she's on melatonin. Now, melatonin is usually for circadian rhythm, sleeping aids, things like that. And that doesn't mean that there's always a problem. Maybe someone just doesn't sleep as well. But keep that in mind as we talk about this case, because it actually is a clue to what's going on with her brain cyst, if you can follow that. So let's keep going. So we started examining her. She's 20/20 in each eye, no visual complaints there. Pupils are great. EOMs are wonderful. Definitely no diplopia. I'm going to show you the video of her in a second of how her eyes were moving as far as saccades, but I'll show you that. Ultimately, the rest of her exam was normal until we got to the dilated portion of the exam. These are her optic nerves. And so I don't know, I hope these show up good, but when I looked at these, I was at first glance, I was like, wait, are these just what I would call crowded or physiologically tight, crowded? That's kind of what I mean by that. Or are these truly edematous? But as you start looking here, and I'm going to try to put in some arrows, especially on that left eye, you can kind of see this halo of kind of some fuzzy borders. And if you had stereo views here, you would see some elevation there as well, specifically left eye more so than the right. And so I really started, the more I looked at this, I think these are swollen. And so I wanted to start going through that process. Now, also remember, I heard that she has a brain tumor, and my suspicion for papilledema was high as soon as I heard that. And so I really honed in on this to look at that. So use history as a clue, of course. When I got the Cirrus OCT here, you can see a little bit of the hotter colors, superior and inferior. And then you can also see it a little bit on the left eye, a little bit more, specifically in that area, maybe superior nasal, where the clinical exam also looked like it was swollen there. And so to me, this is suggestive of some early papilledema that I can see there. You can see the neuroretinal rim thickness is elevated. You're seeing the RNFL being elevated, specifically in that left eye in that area. And we're starting to get some elevation down here as well with that.
Also, Chris,
Yeah.
as you look at the RNFL quadrants, you have looks like in the right eye nasal an 86, and in the left is a 129. Some paper came out some time ago that compared disc edema with optic nerve drusen and OCT, and they found that a nerve fiber layer thickness nasally greater than 88 was more likely to be associated with disc edema than disc drusen.
Awesome. So 88 is a good number to kind of look at.
It's a number to remember.
Yeah, that's cool. Yeah, definitely. That's cool. All right. So as we talked earlier, we get anything weird going on with the optic nerves, we should definitely get a field. And so we got a field on her. Hopefully you guys, I don't know if you guys notice it, but do you notice something that's missing here? The blind spots.
Mhm.
I'm pretty sure my third years forgot to patch as I look back at this. And they told me they did, but I find that a bit hard to believe. But anyway, third years in clinic again. So it makes me wonder if they didn't patch here. But here we go. So I was talking to her about her brain tumor, and I didn't realize that she had them on her phone. And she goes, well, I have my MRIs on the phone. Do you want to see them? I'm like, well, yeah, let me see them. And so she pulled these up. And what I'm trying to highlight here is she has a pineal gland cyst sitting on the back of her dorsal midbrain here that's pushing into her midbrain. And so if you remember, your pupil pathway can be implicated here. Cranial nerve 3 and 4 are in this area. as well. So that's pushing on the back of the brainstem. There's a cyst there. And so that's her brain tumor. Now, also notice if you guys follow her cerebral aqueduct kind of down through here, it gets pretty narrow at the top. And so if you plug that, you can lead to increased intracranial pressure. Essentially, the faucet is running, but the drain is being obstructed. And then that can lead to papilledema, which is what we're seeing in her case. Although asymmetric, there's a little papilledema there related to that as well. So it's kind of blocking off part of the drain. So the answer of what we saw is actually here with that. So, all right.
Yeah, actually, Chris, that
Yeah.
that bears a little bit more of a repetition and an emphasis.
Okay.
You know, little tumors in the right place
Mm.
can cause increased intracranial pressure by disrupting CSF flow. You don't need an avocado in the brain to do it. It can be something very small.
Love it. That's a great point. Yes, sir.
And there's no such thing as a little bit of papilledema. You can't have a touch of papilledema. Little papilledema could mean big brain tumor.
Right. Yes, sir. All right. So this is her. What I was wanting to show you guys here is the specifically her saccades. For the record, when I show you guys patients like this, they have given me full permission to share these videos with you guys like this, just FYI. So
Awesome. The first thing, just going to have you follow the ball there just with your eyes. Good.
So generally speaking, she's able to move her eyes left and right pretty well, up pretty good, and down pretty good. So versions are generally full, no big deal there. She's not noticing double vision. Just trying to show she can move her eyes down, generally pretty good, and up. But if you watch her saccades, especially vertically, what you'll notice is undershoots and up gaze. She struggles to look up more so than down. So her saccades are more accurate down. You can see the undershoots, the skipping as the eyes look up. So she's got some up gaze issues there with her saccades. She's got a little bit of down gaze too with some skips down, but it's largely asymmetric kind of coming up there with that. So, all right. So hopefully you guys saw that. And the reason that's important is saccades are generally affected with things in the dorsal midbrain, specifically vertical saccades can be one of the first signs with that. And so my general joke here is, I mean, sometimes colleagues will ask, well, what are you recording these eye videos with? And I show them this. My students have no idea what this is, and it drives me bonkers because I'm like, the Canon Power Shot. I got this back when I was in college. And they're like, Dr. Borgman, I don't think we were born back then. And it's like a knife to my heart. So I don't know if any of you guys are familiar with this, but this is what I use to record those videos. Unbelievable. Okay. So hopefully I can convince you guys that that tumor is pressing on her dorsal midbrain. Therefore, dorsal midbrain syndrome is something we should talk about based upon some of the findings that we have here. So we can have up gaze paresis. So the inability to look up. Usually saccades are going to happen before pursuits. We can get pupil light near dissociation. So that's as the pupil doesn't respond to light as well as a near target where the eyes will turn in. The pupils will constrict more to a near target than to an actual light like your BIO or transluminator or whatnot. And then we can get lid retraction. So Collier's sign. We can get convergence retraction nystagmus. As they look up, they kind of have this convergence nystagmoid movement in up gaze. And then there are certainly other things that are possible, less common, but possible because of all the things that are housed that are part of the eyes in the dorsal midbrain. So it's really kind of a lesson in anatomy. If we know what's going on there, we can generally predict what's going to happen what's involved, right? And so what I was going to do is show you guys what I mean by a few of these things if we kind of review some general anatomy. And I know hopefully this isn't incredibly deep, but it's just kind of a review to go through this. And so the idea here is this is the midbrain. This is the patient's right eye. This is the patient's left eye. So it's as if you're looking at the patient. And we're going to shine a light first into each pupil down here. And what you're going to notice is the light signal will be carried through the nerve and the pupil fibers back to the pretectal nuclei on either side. There's going to be Bilateral innervation back towards the eye as this splits from the pretectal nuclei with the input back into the Edger-Westphal nucleus. And that's going to happen on both sides, which is why when you shine a light in one eye, both eyes could constrict from this dual innervation, or should constrict in normal functioning pupils anyway. And then those Edger-Westphal nucleus fibers are going to generally speak to your third nerve nucleus, and then that signal is going to pass forward back to the eyes. And then this is my favorite part of this whole slide. Watch the pupils. They're going to do what? They're going to constrict. Man, if I was in live person with you guys, I'd want to hear some oohs and ahs and stuff like that. I'm embarrassed to say how long it took me to do this slide for you guys, but anyway, so this is just a basic quick review of generally the pupil signals from light getting into the eyes and then coming back to cause constriction of the pupils. Okay. So what happens in dorsal midbrain syndrome is we have pupils that are a little bit kind of mid-dilated here, and we're going to have a lesion back here where those connecting fibers from the pretectal nuclei back towards the eye are compressed, damaged, whatnot, and they're not going to allow that signal to be passed. So basically, you're going to shine lights in the eyes. They're going to go back to the pretectal nuclei, but because the lesion is there, the signals are going to stop there, and therefore everything back towards the eye is going to be as if no signals being generated all the way back to the eye, and therefore the pupils do nothing. So this is the light near dissociation with that. The near part, because the near triad is produced in the Edger-Westphal nucleus, so your centers of convergence are right here, we can independently access that system just by vergences and voluntary constriction of the eyes. And so if we get that signal of convergence to start here, we're going to bypass the dorsal midbrain, and then therefore, since we're bypassing the problem, the pupils will constrict and the eyes will converge independent of that lesion. So this is the light near dissociation with this. Anyway, I don't know. Again, I wish I could read minds or see your responses and stuff, but this is how I learn best. And so when I build these, I like building these to show students exactly what's going on and the outcome. So I hope this is helpful. But this made a difference when I saw it. So anyway, kind of cool. Nerding out for a second there. All right. Now, as far as the upgaze pathway that can occur in this dorsal midbrain syndrome, like the saccades and whatnot, we have to know a little bit more of this area. And so we have this INC, or this interstitial nucleus of Cajal. Doesn't matter what we call it, but it's a starting point of where the signal is going to eventually get to. It gets jump started. The signal for upgaze gets started at your rostral interstitial MLF, or your medial longitudinal fasciculus. Really big Latin word, but it starts there. It's going to speak to your interstitial nucleus of Cajal. And then the weird thing is, instead of diving straight down into the third nerve, it actually wraps around. The upgaze fibers wrap around in the posterior commissure back towards the third nerve before they then go to the eye. And that's going to happen bilaterally, basically, here as it feeds into both sides. So the upgaze will pass through, or is believed to pass through, the posterior commissure, and before it then travels towards the eyes through cranial nerve 3 to pull the eyes up. And so if you look at the eyes in here, you'll notice the eyes will move up. No big deal, but that's kind of the general pathway with that. All right, so if we kind of follow that, that's kind of cool. But if I give you that patient again where she's got the lesion back here, what I'm trying to show you is that the signal will still be generated with your RIMLF. It will still speak to your INC, but when those fibers go to pass around dorsally, the lesion's going to block that signal as they wrap around. Therefore, the person's ability to look up is going to go away because those fibers will not be able to talk efficiently to your third nerve, and then everything forward will fall apart. And so the eyes don't really do anything. So in severe dorsal midbrain syndrome, the patient may be able to look down, but they can't really look up. And the earliest sign of this is saccades, like I showed you in this patient. So this patient's saccades are the earliest sign. She had a hard time looking up, but could look down better than she could look up. So I'm just trying to show you where all of this is coming together there. So again, nerding out for the most part, but that's what it is. All right. Yeah, I think this, I'm just going to probably skip through this part because this is a bit too deep with that. All right, so we talked about dorsal midbrain syndrome. We specifically hit upgaze paresis. We kind of described the light near dissociation. Those are the two main things that she had in her case. She did not have Collier's sign, which they don't have to have all of these. She did not have convergence retraction nystagmus, and she didn't have these other symptoms going on either. She just had the papilledema. So in this case, we had those specific findings ultimately. So let me ask you this. If you had to guess, based upon what you know so far, polling question number 4, what do you think would be the most common cause of dorsal midbrain syndrome? I'll put the options here, but I'll let Dr. Salka load it
Yep.
before we talk about it.
Oh,
So as
I
you
think
guys are
I got.
thinking,
I'm sorry, I got the wrong one. Sorry. Close poll. I think it's number. All right, let me take a look. What is it?
the most common cause of dorsal midbrain syndrome, number 4, I believe.
All right, hold on. Common sign. I think Greg may have put these in a little. Okay, he kind of mixed them up when he put these in, but no worries.
Okay.
Now, while people are responding, there was a couple questions.
Okay.
Somebody said good diagram.
Oh, thank you.
So I would also say I would probably suspect that the response when they saw your graphics, Chris, would be much like caveman seeing fire for the first time. Ooh. Now, John mentions a neuro-op paper he came across possibly buried drusen could have been a result of past papilledema. I saw that paper as well. I'm not sure how I feel about that because you don't have to have papilledema for drusen, but William also makes a note of on both your patients, they had poor reliability due to fixation losses. Does it affect your thought process on future testing?
I'm sorry, did I kid with the visual fields? Is that what he was referencing?
The previous case, yeah.
Yeah. I mean, I don't know. I guess we all have patients that are just not good at visual fields. And so my general rule is I'll repeat them, I'll say several times before I give up. But sometimes people can learn to take them over time. And so I guess I take them based upon what's in front of me. If it's complete garbage, I'll put less stock in it. If it sometimes though I can at least garner some type of information. So depends on how much I believe of what's in front of me, but generally speaking, I will repeat them and see if it cleans up with repeat testing, of course, but also keeping in mind, I like objective testing too to kind of correlate with it to see if I believe that it's real. So I would say I generally look at the totality of evidence in front of me and repeat the subjective things as much as I can to see if it'll clean up. Hopefully that will answer the question.
So the most common cause, based upon the results of the poll, people more than half picked up neoplasm, followed by stroke, traumatic brain injury, and demyelinating disease.
Ooh,
Excellent.
interesting. Well, they would be right because about half, per this paper from 2021, were neoplasms. So when I hear dorsal midbrain syndrome, there's approximately 50% chance that there could be a tumor, generally like a pineal gland tumor or something else in that general area could do it as well. Notice strokes are number 2. Other masses are 3, non-neoplastic, and then hydrocephalus, etc. So multiple causes there, but of which neoplasms appear to be the most common with that. So cool. All right. All right. Well, then let me ask you this. What is the most common symptom in dorsal midbrain syndrome?
Okay, well, Greg, when we put these in, kind of mixed a few of them up because they look so similar. So let me go find that one. So we're looking for a symptom, are we?
Yes, sir.
All
Yes, sir.
right.
Symptom this time.
What kind of symptom? I found it here. All right, we have them coming in.
Okay.
Is it diplopia, blurred vision, headache, or imbalance? And I think we're caught up on all the questions.
Okay. I'm glad the diagrams were a little bit of a hit because I'm embarrassed by how much time I've spent on those, but I really, once I did that and realized how they connected, it made everything so much easier for me to understand personally. So I like this.
I'm sure it was like caveman seeing fire for the first time.
It was pretty cool. Yeah.
All right, I'm going to close the poll and display it.
Okay.
Chris, the number one symptoms, diplopia, followed by headache, imbalance, and blurred vision in that order.
Okay. Well, per the same study in 2021, diplopia is the most common symptom per this study, followed by blurred vision, headache, and imbalance. And then notice the difficulty looking up. So even though the up gaze might be another question in here is the most common sign, the symptom is actually lowest on the list for this, or one of the lower ones, I guess I would say. Interesting there. So diplopia is the most common symptom there with that. Oh crap! I think I may have messed that up. Here's the next polling question. If you want to load that, Joe.
Common sign. Let me look for that one. Let's see, Greg, where did you hide that? There we go. Found it. Is it reduced up gaze, convergence, retraction, nystagmus, light near dissociated pupil, or eyelid retraction? Okay, people are weighing in with their responses. Everybody is saying that they are appreciating the diagrams. One person speculated that Andy Lee would probably be impressed.
Oh man, there's a big name.
All right. I guess for the sake of time, I'm going to close the poll and display it. The majority said reduced up gaze, followed by light near dissociated pupil, convergence retraction nystagmus, and nobody bid on eyelid retraction.
All right. Well, again, per this 2021 study, 93% had reduced up gaze with that. So the most common sign is that. So notice the symptom, one of the lower ones were reduced up gaze, but the most common sign that we are going to be able to see as eye doctors is something that they're not necessarily going to complain about. So it's kind of, we got to look for it when our suspicion is there. But notice all these other things that are possible, and it really depends on the size maybe of the tumor and how much it's pushing in that dorsal midbrain area and the structures that are implicated, things like that. But not to go through the whole list, but papilledema is one on the lower end here around that 5%. I thought that would have been higher given how close it is to the cerebral aqueduct in that area, but I was a little surprised on that, but is what it is. But yeah, so you can see those. So reduced up gaze. Now, this is kind of a busy slide, but it's really meant to show you that because of all of the anatomical things in this area, that it's rare to have just one thing or one symptom or one sign. It's actually common to have multiple findings. And so what this is showing is there's in this study again from 2021, the most commonly there were 3 or 4 total signs present in these cases. So there should be more than one thing in most of these cases that would clue you in to dorsal midbrain syndrome. So that's kind of a good clue maybe for clinical stuff if you run across that. It's usually not one sign. So that's also good that if you miss the one sign, there might be other signs there to also clue you into what's going on with that. All right. All right. So we hit dorsal midbrain syndrome there. Let's talk about case number 3, unless there's questions, which I'm happy to answer, but I'll just keep going otherwise.
You're good.
This is, at the time, Dr. Prattis was one of our residents, and she came to me with this case and just wanted me to help weigh in and look at it, which, I think this is a good thing for all of us to think about. I don't know about anybody else, but I certainly don't know everything, and I appreciate having people to go to ask questions and bounce ideas off of. And so I think it's good to have colleagues that we can go to and ask for help. And anyway, she did that really well. She was always asking really good questions. Anyway, this patient that she was kind of presenting to me peripherally here was a 16-year-old male, no trauma, but had been complaining of blurry vision and double vision for about 2 weeks. His history kind of tells you a lot. He's had some major congenital heart issues. He's on the transplant list, so his heart is not beating efficiently. He's at risk for some ischemia because of that and whatnot, and heart failure issues. So he did have an issue a couple weeks prior, and we had to go to the ER for his heart. And at the same time, they found a brain bleed at that same time. So as we start talking to his mom and him, the symptoms all started about that 2 weeks prior. All of his ocular symptoms started at the time he went into the hospital because of his heart. And so they all kind of accumulated at that point. So they did a quick MRI and CT, and they found a hemorrhagic stroke in his brain, which once I hear that, it makes me think of other ways that this can show up in the eye. So I'm going to want to get those MRIs to look at those and the CT scans, which I'll show you. He's on typical medications here that would kind of make sense. The one thing I'm curious on, they did have him on aspirin, even though he had had a hemorrhagic stroke a couple weeks earlier. I'm unsure whether they were just doing the pros and cons, but that seems contraindicated in a person who had just had a hemorrhagic stroke. But nonetheless, he was on it. His vision is okay. It's reduced in that left eye down to 20/40. His pupils are big in the dim lights. They were equal though, around 7 millimeters. And then there was some anisocoria in brighter lights. And so if you look at the pupil size, the right one did not constrict as much as the left one in bright light. So there's some photopic, I guess, anisocoria there, we could say, in brighter conditions. EOMs were generally full, but there was, if you look really close at what I'll show you hopefully on the video, there was some limitations to the EOM movements there. And he did have a significant right hypertropia. So the RHT means right hypertropia, around 12 diopters, prism diopters. The rest of this looked pretty good, as you can see there, but let me show you what I got. And so again, every video that I show you guys, I've been given permission by the patient and or their guardian, as in this case. So they were happy to do that.
Brent, so all you're going to do is look right at my light and
So
follow
again, he had a
that
right
only.
hyper.
So eyes only, okay?
And you can kind of follow this. His left eye is generally down in all gazes. The right eye is going to be higher, and it's going to be worse in that right gaze there. So right gaze, the vertical gets worse. You can notice the lid retraction when he looks to the left. And then again, the bigger, he almost has a little bit of nystagmus there too in right gaze. He's having a little trouble looking up. He can get his eyes up, but he's having a harder time.
See my light down here?
He's also having a little harder time kind of looking down really far as well. So,
Okay. Down, look down again.
so you can see the hyper deviation, a little bit of limitations in up and down gaze. And I'm trying to show you that his right pupil does not constrict to light as well as what we would hope right there. So
Bigger.
So just kind of minimal reaction there. And then the pupil is much smaller on that left side, but still not great reaction to it.
Sorry.
Right.
We're there.
So again, showing you the anisocoria worse in that right eye. Okay.
Right. All right,
All right. So what I did was I started measuring his deviation in different diagnostic action fields, looking for basically Park's 3-step in a short-term measurement of this. So, but he's kind of 12 roughly no matter where I look for the most part. There's no torsion that we could get on double Maddox rod. It did improve. His 12 went down to a 4 when we laid him back. And that's suggestive of a skew deviation, which is a vertical imbalance of the eyes related to a reduced, I'll say, vestibular input. What might be the way of saying that? And we can maybe hit that here in a second. His fields were okay. He might have had a little bit there in that right eye paracentrally, but I think that was ended up being just a learning defect because I didn't really see anything else going on that would largely account for that. But field's generally okay with some depression there on the right. Um, his nerves were okay, but what I wanted to show you wasn't necessarily the nerves or the ganglion cell, but a secondary use if we're paying attention to photos or OCTs. Sometimes there are clues in front of us that we're going to use that are not necessarily the reason we ran the test. And so that's what I wanted to highlight here in this ganglion cell. So my question is, do you guys see it? Do you see a specific finding that has nothing to do with ganglion cell? And so I give you guys a second to look at here. And so once I point it out, you may not be able to unsee it ever again if we're paying attention. This is one of my favorite tricks. It's actually looking at where the fovea is in relationship to the center of the nerve. You'll notice the fovea is much higher compared to the nerve in the right eye. Compared to the left eye, the fovea is much lower than where it normally should be with the left eye. So that also correlates with his right hypertropia. So if I draw a line here and say, do you see it? What I'm trying to emphasize is torsion. You can see the right eye, his right eye, is encyclorotated because that fovea is higher than it should be, and the left eye is excyclorotated. It's lower than it should be. And when we have this binocular torsion where one eye is higher and intorted, the other one is lower and excyclorotated, this is a skew deviation, another form or a way to look at this. And so what I like about this is we get OCTs all the time for different reasons, but there's clues in front of us that we can use off label per se. This is one of my favorite tricks for any vertical diplopia or vertical deviation. I'm going to look at torsion to get a sense for this. So anyway, in this case, this is a skew deviation, which is another clue of what's going on with this. So a skew deviation, again, is going to be a vertical imbalance with, generally, it's really common to have torsion abnormalities like I've highlighted here that basically do not fit a fourth nerve palsy pattern that we would expect. That's when I would be starting to think about skew deviation. A long time ago, here's my weird sense of humor. Does anybody remember learning trigonometry back in high school and being like, this is silly. Well, I'm never going to need to know this. Just let's move on, right? Well, you guys, after 25, 30 years, I found a reason or a use for trigonometry, specifically SOHCAHTOA, if you guys are math nerds, a little bit like me. And so we can also measure tangent, opposite over adjacent, and then figure out the amount of torsion if you wanted to. So all those days in trigonometry where I thought it was a waste of time, I finally found a use. So hey, I can't say I never found it, but anyway, weirdness. You can also see it on other photos here. Now, I will caution you guys that if you look for torsion on Optos, like here, the nature of just sticking your head in the machine and laying it, you're going to induce torsion because you're tilting your head. And so Optos is not the best thing for this, but really anything that you're going to keep your head straight and stick your head in. So OCTs perhaps, or regular fundus photo cameras might be a reasonable way to look for objective torsion with this. And so to me, man, all these vertical deviations that I see anymore, torsion is probably the key for me to help identify, is this a fourth nerve? Is this a skew deviation? Or is this possibly something else I need to look at? But this is a cool trick for that. Dr. Stock, I was going to ask you, you probably already knew this trick, but is this something you use to kind of look for abnormal torsion in some of your, say, diplopia patients?
It's one way to do it. You make some very good observations, and I like the fact that you looked at his positioning in the upright and the supine positioning as well. That's very important.
Mhm.
You know, when you think most time vertical, you know, when you have patients with vertical diplopia, it's gonna be a fourth nerve palsy. But I've always said, and a lot of times these fourth nerve palsies are breakdown. But if it's not a fourth and it's new, laying back, it's probably a skew.
Love it. Amen.
That's how I remember that.
Yeah, I love that one. I feel like there's a ton of people walking around with subtle fourth nerve palsies that I think, at least myself, I've missed in the past because they're not necessarily symptomatic, but they can still be there and we can pick it up on testing like this. And so just having the observational skills to kind of look for any abnormal torsion can clue us into things to look deeper on some of these patients. And when I do that and I work backwards and I see the torsion, And I look back at the patient. It's amazing how many times I've missed that subtle head tilt. And I'm like, good Lord, it's been there this whole time. So it's just another clue. This is this patient's CT scan. And in this case, what I'm trying to show you is the hemorrhage at his midbrain. So he's got right here, blood generally is a little bit hyper dense in these signals. It's not as dense as bone and calcium per se, but he's got a hemorrhage there in his midbrain. And the sagittal cut, again, you can see the hemorrhage in his midbrain, which is going to be responsible for really everything that we're seeing in this case, as far as his vertical deviation, meaning his skew, his diplopia, those sorts of things. The pupils, all those things are going to be from that area. These are his MRIs. You can see again in the midbrain, he's got this kind of centrally located hemorrhage right in the dead center of the midbrain, again, in those areas for pupils, EOMs, things like that. You can see on this swan scan, this dark area is also telling you, or another way of seeing blood there. And then on this Bravo scan, sagittally, you can again see the ring of blood there as well in the midbrain. So just multiple ways of just showing you the midbrain and things like that. And so this is just another version of dorsal midbrain syndrome. He's got the upgaze paresis. He's struggling to look up and down. He's got the diplopia, the anisocoria, but he didn't have the convergence retraction nystagmus, and I didn't see an obvious Collier's sign. Although I wonder if it would be a variation. If you remember when he looked to his left, that lid opened up. I'm thinking through that. I'm wondering if that was kind of a variation of Collier's sign there with the lid retraction. I guess I'd have to think through that a bit more. But he had several findings nonetheless that kind of fits there with his imaging. And so if you remember, the second most common cause was stroke. And in this case, it'd be a hemorrhagic stroke in this unfortunate kid. And if we go back to those common symptoms that we've talked about, he had diplopia and blurred vision. He didn't really notice difficulty looking up. So his symptom was he didn't notice it, but we saw it. And so we should probably put another arrow here for the reduced upgaze. He had a little bit of struggling to do that, but he also had these other findings as well that we've highlighted. So they can show up with multiple findings. It doesn't necessarily have to be all at the same time. And again, to remind you, it's common to have more than one finding in these dorsal midbrain syndromes. Pretty common to have a handful or so. So in this guy's case, he had anisocoria. He definitely had a dorsal midbrain syndrome because of the imaging proving it. He had a skew deviation. Maybe he had a little INO in there as far as his ability to move the eyes. Hard to say. Maybe some third nerve involvement. But nonetheless, it all localizes to the same area. The question marks are more of, well, is that or is it not? But I feel pretty confident saying it's a dorsal midbrain syndrome with what we have here. So, all right, Dr. Sauk, anything you would like to add on that or keep rolling?
Keep rolling about 10 minutes or you can get through one more case. That'd be great, but you only
Okay.
have about 10.
Okay, perfect. I can do that. No problem. All right, here's a 50-year-old female that's having trouble with her side vision. This has been going on for 2 to 3 years. She is very aware of this going on, and she's so scared of doctors. And she has some, as I highlighted here, some mental health issues. These are not mild. She's very severe depression, very severe anxiety, very severe bipolarism. It took everything she had to come into the eye doctor because she let this get so bad from when she first noticed it because of her mental health barriers. She just could not bring herself in until this visit. And so it just highlights the importance of keeping in mind what patients have to struggle with sometimes, the mental blocks and things like that. So anyway, she's trying to paint that picture of she's a severe patient with that. She's extremely anxious and nervous, as would be expected, kind of given her mental health situation here as well. Her acuity is down, which is kind of what she was complaining about. Her pupils are pretty good here. I didn't see anything major jumping out on that. EOMs looked good. Confrontations, though, did have some suspicious temporal depressions in each eye. The cover test, as far as we could see, was ortho, though. And then she did have some pale optic nerves as well. So I'll show you those. So these are her fundus photos, and my hope is that you see the nerves. They are pale in color. Maybe the right eye is a little more pale than the left, but there is pallor, at least temporally, in both eyes, and and more so in the right. I guess what I'm trying to say. So, as we mentioned earlier, the first thing we should think about with any optic atrophy is, can we get a reasonable visual field or a reliable one? And so then obviously here, this is concerning. Hopefully you guys would agree that this is a bitemporal hemianopic field defect, which is concerning for one thing until proven otherwise at this point. And that would be a chiasm problem, specifically a pituitary adenoma is where I'm going with that, or at least that's the most likely thing. I wanted to show you some of the changes on the OCT images. Obviously, there's can be thinning on the RNFL, and if you notice here, it's kind of picking up. The right eye looks a little more atrophic than the left eye, which is kind of what I saw clinically as far as the amount of pallor between the eyes. And the GCC, or the ganglion cell analysis, is also being thin. Now, the right eye, it's like all gone here. But one thing I wanted to highlight, and this would be something I'd love to hear your opinion on, Dr. Sauka. On the GCC, if you notice, if you draw this imaginary vertical line through the fovea, you kind of see this rough respect of the vertical midline where the temporal side is actually thicker than the nasal, meaning nasal thinning that kind of respects the vertical there. Now, this is what I'd love to have you weigh in on, Dr. Sauka. Like when you see that, at least what I see is nasal thinning. And when it respects the vertical like that, it makes me wonder, is there something neuro going on like a tumor at the chiasm? Is that a finding that you commonly use too?
The answer is yes. You can have very similar to what you see on the visual field, the neurogenicity in the function. There can be neurogenicity in the structure. Now, I'm going to caution you, it doesn't happen every time.
Mhm.
You know, there
Yeah,
there there are times when I have had chiasmal masses where this rule was not obeyed. It's actually fairly well known in the neuro-ophthalmology circles, and frankly, they're just not impressed by it. It's like, okay, it is.
gotcha.
That's
Yeah.
their response is that's nice.
Fair enough. I personally do look for this
Mhm.
sign just to see, is there something asymmetry there that would
Yeah.
clue me into a question of, is this neuro? Is it possible I'm overlooking something? And so I certainly would agree it's not there all the time. But when I do see it, it makes me pause and go,
But
do I need to rethink my differential?
if you look at the thickness map, you can see something, but if you look at the deviation map, you don't see it.
Right.
And that's analogous to looking at the pattern deviation and ignoring the grayscale on a visual field.
Ooh, that's a good point. I never thought of it that way. That's a great point. Nice. Thank you, sir. Appreciate you weighing in on that. So obviously now we're thinking about optic chiasm because of the bitemporal hemianopia. So we got the brain MRI ordered, which was a chore because, again, remember her mental health situation. She is very anxious, does not like to leave her home. And so we had to like majorly pull some strings to get her to get to the MRI and get the scans for what we wanted. And because I knew inevitably we're going to find something not good, I kind of also started the neurosurgery consult as we were getting the MRI ordered. So here's I believe my last question for the night, Dr. Salk. If you do you want to do
Mhm.
this one, or are we running too tight on time?
Why don't we just finish the case?
Okay, yes, sir. So
Hmm.
basically, here the four main options I have for you guys is this, but the most common one is adenoma. That's going to be most likely. And so, anyway, in this case, we ordered the MRI, and on this T1 without contrast, you can see this mass near her optic chiasm right here in the sellar region. And then as we start working through this, as they start adding contrast, this thing is taking up contrast. But then the pattern is in a way that actually doesn't quite fit with an adenoma. So it's actually not a pituitary tumor. In this case, it ends up being a meningioma or a sellar meningioma, tuberculum sellar meningioma. And so this thing's growing and it's starting to press on those surrounding structures. And so in this case, it wasn't exactly what I thought. I was going to bet my left hand that this thing was going to be a pituitary adenoma, but it ended up being a meningioma. So I guess the learning point here is when you see field defects that are neuro, chase what's most common, in this case, maybe an adenoma, but the appropriate workup should identify the underlying cause, at least in the vast majority of cases, and then we can address it from there. And so in this case, it was one of the less likely ones, the meningioma. And since I had her set up with neurosurgery, They got her in pretty quick and went in and resected that tumor. And to date, though, because of her mental health stuff, she's not come back for follow-up. So I hope she's gotten better. I really do, but I don't have that for you guys. But at least I feel good that we caught it. We got her in the right hands, and this gives her her best chance of not losing further vision to the best of our ability with that. So, all right.
Yeah, I think another thing that's very important is the fact that she had structural loss. And as you say, when you have the structural loss, that functional recovery is less likely. Now, if the structure was good, there is a potential that they can have some recovery, though I would not guarantee it. I recently saw a patient with a planum sphenoidal meningioma who had field loss in one eye, and there is a tumor wrapped around the optic nerve, but the OCT, nerve fibrillary, and GC were still pristine. So what had happened was after I finally got her to a skull-based specialist. He removed most of the tumor. Her vision went from a 20/60 to a 20/15, and her visual field completely recovered because the structure was still good.
That makes sense. That's pretty cool. Dr. Sauer, can I ask you a question? Because
Yeah.
just, some wisdom from a guy that's been in it longer than me. It's scary to me sometimes of the things that can be going wrong in our heads and our orbits and us not really see anything with it. So it makes me wonder, like, how many of us are walking around with bad things that we don't know about? Does that ever like cross your mind? Like everyone should get a brain MRI as like a screening process or something like that? Or is that not something that you really think about?
Well, I don't think about it. If you ask me, I think everybody should get a full body
Yeah.
MRI to look for other things that may be there. There are a lot of pituitary adenomas out there. I forget what the incidence is in the general population, but it's fairly common. And most people will die not knowing that they've had one. We
Mhm.
often find them just on incidental imaging, and they mean nothing. There's the simple coincidentaloma. But in your case, you may say, well, you missed that it was not an adenoma as you thought it was a meningioma. To me, the tumor type and tissue type doesn't matter. You knew right off it was chiasmal disease.
Mhm.
So you
Yes,
knew
sir.
exactly what it was. And that's why this is a team sport. Radiology helps identify what it is. They can even give you some suggestions. Neurosurgery takes over. You're monitoring the patient, not here afterwards, but before you make the diagnosis. If the patient did come back for follow-up, you could follow her over time because sometimes they can't get all the tumor out neurosurgically because of damage to other structures, and they still have to be monitored.
Yes, sir. Yes, sir. Makes sense. Makes sense.
Well, I think what we're going to do is we're going to finish our housekeeping and wrap up. I think there's one more question here. Is bow tie pallor something that you notice in chiasmal lesions, or is it just temporal pallor?
I would say generally when we talk about bow tie optic atrophy, we are usually talking about an optic tract lesion more
Mhm.
so than an optic chiasm lesion. And so I guess you would deduce that from the fields and generally from potential respect to the vertical on the GCC, which might correlate with those fields as well. I guess that's how I
Excellent.
would answer that. What do you
Mhm.
think, Dr. Salka?
I agree. Bow tie pallor. I'm thinking tract and or lateral geniculate.
Mhm.
You can get temporal pallor from a chiasmal mass. You can have no pallor. You can have diffuse pallor. I have seen mass lesions of different types that manifested as good vision, reduced vision, no papilledema, disc pallor, no disc pallor. The underlying thing is mass lesions don't behave typically. They can give you anything.
Yeah. So maybe look at the totality of the evidence, everything in front of you, that sort of
Mhm.
thing would be helpful.
And when in doubt, You know, I've done about 200 medical malpractice cases as an expert witness, and I can't think of a single case where the optometrist being sued had done neuroimaging, blood work, or culture.
Wow. That's
More
awesome.
information is almost always a good, more evaluation is almost always a good thing.
That's awesome.
So with that, if you want to unshare,
Yep. Yes, sir.
I'm going to share my final housekeeping. So that was it. That was my favorite neuro cases. I thought that was, Chris, I thought that was fantastic.
Oh, thanks, man.
I mean,
really
there is a
appreciate it.
lot of ground covered, electrodiagnostic testing, genetic testing, uh, neuroimaging. I mean, there really was a plethora of information that you got through in, I think, a succinct and engaging way by bringing it to case-based care. So I think, Chris, that was a fantastic job. I really enjoyed it. And I do thank you so much for doing this.
I
Greg and I
appreciate
are
the
very
opportunity.
pleased to know you and have you at our meetings and help with our education. So thank you so much.
Well, thanks for having me. I appreciate it. And thank
Mhm.
you for the kind words and the compliments. I hope everyone else learned something too today. That'd be great. So thank you all. Appreciate it.